Good morning, everyone, and welcome to the Penn State College of Medicine COVID-19 Echo Series. We're delighted to have you join us for today's session. It's wonderful to see some familiar names and faces online. My name is Jackie Sable. I'm a member of the Echo team, and I'll be facilitating today's session. A few quick announcements before we begin. If you've not already done so, please put your name, email address, and affiliation in the chat box for our record-keeping purposes. Please stay muted unless you're speaking. You can use *6 on your phone or the microphone icon on your Zoom screen to mute and unmute. You can also use the chat for communicating. We realize that question and answer time is important to you, and we'll try to categorize and address as many questions as possible. But if there are any unanswered questions afterwards, we will always follow up via email. Please remember that no personally identifiable information is allowed if we're discussing cases. We are recording these sessions and we share all materials and recordings after the session. In the spirit of Echo's All Teach, All Learn, we're on a first name basis during sessions. For anyone who's new to Echo, our Echo sessions will always begin with a brief lecture and they're followed by either a case discussion or question and answer time. Today's session will include a lecture on multisystem inflammatory syndrome in children by Drs. Michael Beck, Kimberly Hays, and Robert Tunks, and this will be followed by our question and answer period. During the lecture, please feel free to put your questions into the chat. We do have a team of specialists from Penn State Health online, and they'll help to field questions, but remember that this is all teach, all learn, so everyone can share both questions and answers, and we will address all chat questions after the lecture if they're not addressed by anyone in the meantime. And with that, I'm going to turn things over to our presenters, and they can introduce themselves as they go through their lecture.
Well, thank you. Good morning, everyone. This is quite a unique opportunity, so I appreciate everybody attending so early in the morning. And hopefully we can convey some information and distill it down to a lot of information to a short talk. My name is Michael Beck. I'm Pediatric Hospital Medicine, and I'll let Dr. Tunks and Hayes introduce themselves.
Good morning, everyone. My name is Robert Tunks. I'm one of the pediatric cardiologists at Penn State, and thank you all for being here this morning, and we're eager to give this talk this morning.
Good morning. My name is Kimberly Hays. I'm one of the pediatric rheumatologists at Penn State. Thank you for the opportunity as well, and we look forward to speaking with you and answering any questions you may have.
Let's go to the next slide, Jackie. So I thought I'd first start with a quick introduction about where we were and where we are. And from a pediatric hospital side of things, I've been tracking this, I think, probably since May 5th. And starting with the first sentence in the introduction was when Dr. Levine and their group in the United Kingdom noticed an interesting phenotype that was emerging as well in Italy and Spain and France, and they were sort of coming together. They were seeing the same thing, but they were seeing it at different times. And they didn't know what it was, but it was a condition that resembled toxic shock. It resembled Kawasaki's, but they were anecdotally seeing that these were sicker than the average kid with Kawasaki's. In fact, many of them were in the ICU, where, as many of us know who do take Kawasaki's, care of Kawasaki's, they're sick, but they don't end up in the ICU. And they were seeing a disproportionate number of these young kids who were on the older side of it as well, who had some inexplicable lab abnormalities, clinical phenotypes, and there's a broad spectrum of this disease. So initially they didn't know what to call it, so they called it a unknown syndrome in kids, and they called it pediatric inflammatory system in children, so PIMS, and then they came up with these other nomenclature of PIMS, Kawasaki type, PIMS with toxic shock, or PIMS with hypercytokine. And what they were noticing, they had the same features of fever. In fact, almost universally, that was a feature. Significant number of gastrointestinal symptoms, which included anything from the vomiting, abdominal pain, a lot of diarrhea. Some people had mucositis, or not mucositis, but ileitis. Some also had pancreatitis. A large percent had mucocutaneous features. But what they were also noticing was a lot of these kids were sicker with less respiratory things, but a lot of cardiac dysfunction, whether it was myocarditis and aneurysms. Some of them were having conduction defects as well, all in the setting of hyperinflammatory state. So there was clearly an overlap with Kawasaki features, toxic shock syndrome, and then there was an association with COVID, because what they were also finding around 2 to 4 weeks out of its presentation through the countries, they were starting to see a ramp up, and I'll show you a slide of that, of incidents of reported events of this Kawasaki disease, or PIMS. And then it was until May 14th, a number of webinars came up through, and then New York started presenting it as well, because they had a large data set of cases, and they were seeing the same pattern. Kawasaki type features, sicker than the average Kawasaki's, a lot of them are in the ICU, as you'll see, and decided to name it Multisystem Inflammatory Disease in children. And even at the time of us making our slides, there's been some new data has come through. So we'll try to keep everything as up to date as possible. But as you can imagine, it's like building a plane while you're flying it. So we'll keep everything up to date. So in terms of the phenotype, the diagnosis is this, and you'll see fever. They will have muscle aches and pains if they're old enough to complain of it. A large percent will have conjunctivitis and rash, lymphadenitis, but very few percent we're going to have the exact features of Kawasaki's in terms of the finished product. A lot of them will have neurologic, maybe 10 or 20% will have headache, neurologic events, whether it's just encephalopathy. The myocarditis is a feared complication. Dr. Tunks will talk more about that later. And those are always evidenced by elevated brain natriuretic peptides and troponins. Yeah. Some will have hypoxia and pulmonary infiltration on chest X-ray, and I could talk to you more about some of the phenotype with that. Again, like I said, 70, if not even more, probably 90% will have nausea, vomiting, or GI symptoms. And then we'll have hematologic abnormalities. Some will have some acute kidney injury as well, and associated with hyponatremia. Next slide. This is just a slide to show where we've been in March to May. And this came from the CDC website, and it was data that was compiled out of Columbia University and New York Presbyterian. And really all it is trying to show is you started to see the rise in the curve of incidences of COVID, SARS-CoV-2 infections and COVID. And then around 4 weeks after onset, so March 8th to April, you start to see this emergence, which is 4 weeks later, of some of the MISC cases. And as you sort of march along from March 29th into April 26th, which is a month later, you start to see again that 4-week increments of increasing MISC reporting. So this is just really to show you, I think when you start taking your history, it's if you have a diagnosed history or exposure of a child with known exposure of COVID, or you have a known diagnosis of COVID, the kids are going to have it. It's going to be around 2 to 4 weeks out as a median. It can occur out as far as 6 weeks. Next slide. Characteristics of MISC is something we've seen as well. This came out of the CDC. The N, as you see, is 342 cases as of July. And what they saw in the United Kingdom was the median age is around 10 years. And that's what we're seeing here. The median age here with more patients, their population had 37 kids. This has 342. So I think it's representative of the reality. But these kids are older. So where we think of Kawasaki's being a younger, less than 5 years of age, these are kids on the older age. Unfortunately, it can hit the spectrum of ages. So you'll see kids less than 1 with it, but the median is around 8 years of age. The other part about it is the ethnicity with it as well. So when they were reporting this United Kingdom, their population was pretty homogeneous, but only 3 to 13% of their population in the United Kingdom Wales had African American or African or African Caribbean descent. They were still representing about 56 or 60% of the cases. So, and that's sort of what we're seeing here. 40% of our cases are Latino Hispanic, and then another 30% are non-Hispanic Black. So this is also in terms of profiling. If you start to piece these together, Hispanic or Black or African descent, and they present with Kawasaki features in an area where there's a high community prevalence, you have to get your ear to the tracks and worry about it. Next slide. So this is just a case definition. This is for you to keep track of. Essentially, it's anybody who's less than 21 who presents with fever. And honestly, there was some discussions about it, whether you can see MISC without fevers. I think most people would say that's probably not going to be the case. But you can see mild cases of it, to be sure. And that's the tricky part about it. And that's sort of why we're having this talk. They will have at least 2 organ involvement most of them are going to see with GI, as I'll show you, but they can have any organ involvement, as you see there. You have to have no alternative plausible diagnosis, which I do want to spend a couple slides about because I don't want us missing the common things. And you have to have a recent exposure to COVID-2, either by PCR or serology or antigen testing. Next slide. So this is just some of the differentials that I put together, and there's another slide after this that will show you a little broader, but these are the infectious things that we're going to see. Or, you know, Kawasaki's is something we worry about. Staphylococcal or non-staphylococcal toxic shock, whether it's menstrual or non-menstrual toxic shock, is something that we have to be mindful of. So you're going to see older kids, so toxic shock features will have conjunctivitis, will have mucosal changes and shocky appearance. So this can look just very much like menstrual and non-menstrual toxic shock. So that has to be on your differential. Scarlet fever isn't usually as sick appearing, but it certainly is in the differential, so strep. Stevens-Johnson or mycoplasma-related mucositis is something also to consider. And then systemic onset juvenile arthritis are some of the other things that you'll see. Next slide. Other things in differential, I pulled this off of UpToDate, I think are also important. Other viruses are in there. If the shoe fits and they're immunosuppressed, and you have to think about other fungal and other opportunistic infections in a child who's on immunosuppressants. The one thing that we have to worry about at this time of year, although Lyme doesn't usually get this sick, but what other tick-borne diseases like rickettsia, ehrlichiosis, and Rocky Mountain spotted fever is something to think in your differential. And the other one would be meningococcemias. You don't want to miss some of these treatable bacterial infections that look very similarly. If they're on medicines, anti-epileptics, DRESS syndrome would be something you have to worry about as well. And the other ones we talked about, serum sickness and other systemic onset juvenile arthritis. So I don't want us to get too caught up with MISP because it's not exceedingly common, but it's out there. I just did a quick assessment of the state of Pennsylvania. We had 121,000 cases in the state of COVID. The incidence of COVID in kids is around 5 to 7%. That means at the state level, we probably have somewhere between 6,000 and 9,000 kids with COVID. But the incidence of MISC is about 0.4 to 0.7%. This is just to go over this came out of the New England Journal study. This came out as 186 kids who were selected from the hospital. So this doesn't necessarily capture all of the outpatient cases, but it goes through in the bold the GI symptoms, the organ system that be involved. In sort of anticipation of your questions, GI involvement is exceedingly common. 90% of the kids are going to have GI involvement, and that could be a variety of things, as you see here. Hematologic involvement comes up very commonly in the questions we have, even in a hospital. How many of these kids get PEs or DVTs? There are other reasons to anticoagulate, which Dr. Tunks will talk about. But DVT and PE, as you see, of the age groups, it's broken down to 3 age groups. There was no one less than 5 years of age who had a DVT or PE, and only 1% in the 5 to 12 year range did. You start to say 7% above 13 to 20 years of age. So those kids who have MISC will behave a little more adultish, and they're probably, some of these are Lyme provoked more than likely, but the incidence of them are low. But then respiratory insufficiency and cardiac involvement are the most concerning features. Go ahead, next slide. This is just to go over some of the lab findings that you're going to see on some of these kids that come into the ED or in your clinic or urgent care centers that you're going to take care of. And again, it's broken down by age groups less than 5, 5 to 12, 13 to 20, and then overall. And the vertical hash line is really just to show about 75%. So you're going to see a lot of lymphopenia in these kids with neutrophilia. Lymphopenia is defined by less than 1,000. So if you see a kid with neutrophilia, age group is older with fevers and lymphopenia, that's something to start worrying about. Many of them will have anemia, that is non-hemolytic. Indifference to Kawasaki's, where you see thrombocytosis, you'll see a lot more incidence of thrombocytopenia, which again is a subtle clue that you're worried about, you should be worried about MISC. And a percent of these kids will even be less than 100,000. D-dimers are significantly elevated. A lot of them have coagulopathy, as you see here. Large percent will have hypoalbuminemia. CRPs are above greater than 3. In fact, can be above 10. And ferritins and cetyrates and troponins. Next slide. These are just some of the types of treatments that we're going to offer at any tertiary center that's local to you. There is a fair amount of variability in how we manage these kids. And that's something you're going to want to tell your families when you're referring out or to a tertiary quaternary center, that there's a lot of variety of how we manage these kids. And having just been on a webinar with the American College of Rheumatology, there is still a significant amount of variation. But at the end of the day, they're going to get the care that they need. And that's definitely something you want to reassure your families about. Most people are using IVIG, even for the milder cases. What we also know with Kawasaki's related disease with SARS-CoV-2, greater than 50% of these kids are IVIG resistant. And how you identify those children a priori is tricky, but we know that they are. So some people are going straight to low-dose corticosteroids at 1 to 2 mg per kg right off the bat. Some people are trying the first round of IVIG with a cap at 70 grams if it's weight-based. And then some, 56% or 60% require some inotrope or vasopressor support, which is something you have to be mindful of if you have a child who's not responsive with volume resuscitation. The immunomodulators is what Kim is going to talk to you about, and 25% are going to require some mechanical or non-invasive ventilation, and some kids require ECMO. Next slide. This is the order set that we have here at the medical center. When we first put this together, we didn't have a tiered approach, although I think there's a good evidence to doing tiered approaches, because we just thought that all these kids were going to come in shock and extremis, when the reality is I think there's a broad spectrum of this disease. So it's probably better to find a way of balancing over-testing versus under-testing. So the sensitivity of these tiered approaches is not there. But what we'll do is a child who comes into the emergency room will probably get at least a first round of tests, which is going to include a comprehensive panel, which includes liver function tests. CBCS for differential is going to be important, looking for thrombocytopenia or thrombocytosis and lymphopenia and neutrophilia and anemia. Coags are not, that's variation how we order that. We always will get CRP and SED rates as a screener. We use ferritins to see if there's a trend for predicting cytokine storm syndrome, which Kim will talk to you about. Well, obviously we'll get blood and urine cultures. And these are some of the other labs we'll get if we start to think that they're requiring or meeting criteria for multisystem inflammatory disease. Next slide. One thing I left out on that is also we will have a order set that includes antibiotics. So you do want to consider doxycycline if the history fits for Rocky Mountain spotted fever. We have clindamycin and other broad spectrum antibiotic coverage for any kids who are worried about toxic shock as well. Just so you know, when you're referring these patients to at least to Hershey, I can tell you with almost 100% certainty, they're going to see infectious disease. They're going to see cardiology more than likely, especially if they have any biomarker leak with troponins or BNP, and more than likely going to see rheumatology during the hospitalization. Small percent of these kids do see hematology, and then a smaller percent are going to see nephrologists. But that's something you're going to want to provide your families some reassurance. They're going to see a lot of specialists. It's going to be scary, but they're going to be taken care of. And that's, I think, in terms of anticipatory guidance for you, they're going to see at least 3 of these. Next slide. And this is, I think, my final slide is really just information for you to have if you're in the state of Pennsylvania, or if you're in a different state. Please contact your local state Department of Health for how you report this. Ours is 1-877-724-3258. Right now we have 42 confirmed cases in the state of Pennsylvania. 19 are currently under investigation and 12 ruled out. But please report them if you are concerned about the multisystem inflammatory. It gives us a good sense of what we're seeing in the state. Next slide.
Well, good morning once again, everyone. My name is Robert Tunks, one of the pediatric cardiologists, and we'll spend the next several slides talking about the cardiovascular manifestations of multisystem inflammatory syndrome. Next slide, please. As Dr. Beck mentioned, the amount of data coming out about this new disease process is marked. And it seems like almost every day there's new papers, there's new literature coming out. So we are very much learning about this new entity. But I will point you to these 2 papers here that I found to be particularly quite excellent as it pertains to cardiac manifestations. The first was published in the New England Journal of Medicine. That was an overview the US experience thus far. It looked at 86 patients from 26 states with MIS-C. And the second paper here was published in Circulation. It was a European review out of France and Switzerland that looked at their experience with dealing with heart failure in kids who were 2 to 16 years old. So the data that I'll show as we kind of put this together for where we're at right now with MIS-C largely comes from these two really nice papers. Next slide, please. So looking at the US experience thus far, this is a little bit of review from what we have said before, but it's important to know that this is truly a multi-organ system, disease process. So GI symptoms really were the thing that caught a lot of people's eye initially, that how common GI manifestations are. Certainly we've learned that cardiovascular manifestations are also extremely common, affecting 80% of these patients. And the majority had at least 4 organ systems involved. So important to keep that roadmap in mind as you evaluate these children. We'll move on to the next slide, please. This is just a map of the US from the New England Journal paper that came out now just a couple of months ago, looking at MIS-C incidence by state. And what you can see in this early map is there's certainly a predominance in New England, in the Northeast area of the country here, with Pennsylvania being right next door here. And over time, more up-to-date information, I looked at the CDC webpage just a few days ago, and as of early August, we're now seeing MIS-C in the majority of states across the country, with a continued predominance of cases in the Northeast. The state of Pennsylvania was actually found to be in the second highest tier of MIS-C incidence when all the states were considered. So this is a growing entity, one that we're seeing and I presume will continue to see. Next slide. In terms of the cardiac clinical presentations, it can be varied, but we'll focus on a couple of these today that are more common. The first of which is that of ventricular dysfunction and potential cardiogenic shock. A myocarditis type picture with significantly depressed function and altered hemodynamics. As Dr. Beck mentioned, this certainly can mimic Kawasaki disease, and we'll go into more detail about that in a few slides. But certainly coronary artery aneurysms are something that is possible and that is a significant finding with this syndrome. Other patients can present with arrhythmias. Anecdotally, we've had one patient here at our center who had transient secondary heart block that luckily recovered. Other patients can come in with a pericarditis type picture or significant pericardial effusion. Next slide. The laboratory evidence, again, from a cardiac perspective, elevated brain natriuretic peptide is around 3/4 of the patients that we've seen so far who have cardiac findings. One paper that I was reading earlier this week had a strategy of patients with prolonged fever. They're now checking BNPs, just given that predominance. Elevated troponins were found in around half. And as was previously mentioned, elevated inflammatory markers, D-dimers, lymphopenia, again, was a common feature. And I would point your attention to the potential for metabolic acidosis as a negative sign that I would ask you to worry about their hemodynamic status and worry about their heart function if they do have significant acidosis. In terms of cardiac testing, EKG and echocardiogram would be indicated if you're seeing this type of presentation or lab evidence. And importantly, these studies would be followed serially to make sure we're not seeing changes in the patient's cardiac status. Next slide. So spending some time on ventricular dysfunction and shock. This is unfortunately a relatively common presentation type that's been described. And importantly, many patients with MISC ultimately require inotropic support. 48% by the review here in the United States, up to 80% out of the European paper needed inotropes. Luckily, ECMO was less common, only 4% here in the US per the New England Journal, but more frequent in Europe. So I think we need to be mindful of that a significant number of these kids may ultimately require mechanical support. But suffice it to say, these patients can be quite sick and ultimately frequently require the ICU. 80 to 83% in the series that I mentioned required ICU level management, at least for several days. Next slide. These images are just some images showing some differences in left ventricular systolic function that we can see. The left pane, if we can play that movie, please. This is a patient from our hospital that had MISC and ultimately was found to have low normal left ventricular systolic function and ultimately recovered into a normal to hyperdynamic range before leaving the hospital. What we're concerned about is the potential for the slide on the right. So if we play that, that demonstrates a severely depressed dysfunctional left ventricle that's severely dilated. And I'll admit, this is not from a patient with MISC, but it is from a patient with myocarditis of a different etiology. So this degree of depression is potentially possible, and this is the type of patient you're worried about needing ECMO support and coming in extremis. Next slide. Briefly to talk about outcomes, thus far, ventricular recovery has been more common than not, which is good. Just over 70% in the European paper demonstrated complete normalization of function after treatment. And in the United States, the New England Journal authors focused on death rates. They reported those and outcomes after the hospital. 70% were discharged alive, and there was a 2% death rate recorded. So not overly high, but not zero. 3 of the 4 patients who died did require ECMO. So certainly if you're going down the road of needing mechanical circulatory support, that is certainly a negative thing. However, I will very much admit that it appears that the jury is still out here. As I mentioned, we're still in the learning phase about this process, about where outcomes going to settle, certainly what are the long-term ramifications. But 28% of the patients were still hospitalized as of May in the US experience. Next slide. There certainly are links to Kawasaki disease in terms of presentation types. This slide just briefly reviews the cardinal features of Kawasaki, certainly including fever of 5 days or longer, also rash, non-purulent conjunctivitis, oral mucosa changes, typically unilateral cervical adenopathy, palmar and plantar erythema, and then, of course, from a cardiac perspective, the concern for coronary artery aneurysms. Next slide. Kawasaki disease and MISC, as I mentioned, have parallels. And what we've seen so far is that greater than 1/3 of the kids we've seen have some features of Kawasaki. However, over half of them would not have met a formal diagnosis of either complete or incomplete Kawasaki disease from what we've seen. So it's a mixed picture. There's some overlaps, but not a complete overlap is most usual. Important differences, however, that have been seen. One, the nature of the cardiac involvement seems to be somewhat different in that significant depression of LV function, a shock type presentation seems much more common in MISC, affecting up to half of these kids, compared to only around 5% of Kawasaki disease, or so-called garden variety Kawasaki disease usually does not come in with a massive depression of LV function is the usual story. So more shock in MISC. The ethnicity differences are there, and then MISC patients have been more commonly the African or Afro-Caribbean ethnicity, again, somewhat different from KD. And while those patients with Kawasaki type, we'll call it MISC, have been younger in general, overall, the age range for MISC is affecting older kids, as Dr. Beck mentioned, and potentially more arrhythmias as well in the MISC group as compared to purely Kawasaki group. Next slide, please. Coronary artery aneurysms. Thus far, we have not seen cases of significant aneurysms at Penn State, but again, looking at the international literature, anywhere from 8 to 17% of cases did have coronary artery aneurysmal involvement. From the Kawasaki literature, this is just a brief reminder of how we grade coronary artery aneurysms in terms of severity. We look at Z-scores that are measurements that are indexed to body surface area, as well as absolute dimension when these aneurysms get really large. And so, large or giant aneurysms, as we call it, have a Z-score of greater than or equal to 10, or an absolute dimension of greater than or equal to 8 millimeters. Next slide. These are just some images demonstrating significant aneurysmal changes. Again, these are not from our MISC patients, but rather these are patients with KD. But on the left here, you can see an axial slice of a CT image showing the aortic root here. And just to give you a sense of how large these coronaries can be, this is the proximal right coronary artery, which is a significant proportion of the aortic root size. So this is a severe aneurysm. And this is the same heart showing the left main coronary artery here, which is normal in caliber compared to a severely ectatic and dilated right coronary. Next slide. Some patients with coronary artery aneurysms can be particularly unlucky, and we don't know who this affects, but this patient has multiple aneurysms. There's a large aneurysm of the left main here. Again, for comparison, this is your aorta, and again, you could see the caliber of the left main is really approaching that of the nearby vessel, which is the left pulmonary artery. Here is the right coronary, and so there's a right coronary artery aneurysm as well, and then a significant thrombus within that right coronary to boot. So can be very complex disease and multifaceted disease. Next slide. In terms of anticoagulation, I'll leave the remainder of the treatment options and specifics to Dr. Hays, but as it pertains to anticoagulation in the setting of coronary concerns, our approach to date have been that if there are features of Kawasaki disease, we would advocate therapy with aspirin plus IVIG, as you would with a Kawasaki patient. If there are large or giant aneurysms, we would favor dual therapy with aspirin as well as either Lovenox or Coumadin. If you are one of those patients who happens to have multiple aneurysms or a single coronary that's affected by very complex aneurysmal burden, we also talk about dual therapy. Some of these kiddos can have thromboses within the coronaries, as I mentioned. That's of course a serious situation, and those patients are managed usually by TPA. And then finally, the situation that could happen is that the coronaries are normal, but the left ventricular systolic function is poor. And if that's the situation, I would consider treating them like a heart failure patient with some level of anticoagulation on board, at least aspirin in that situation for prophylaxis against thrombus formation. Next slide. Closing considerations. I think that taken all together, this is a new entity and one that we're learning about that has the potential for very serious cardiovascular manifestation and other manifestation. But I'd stress the importance of early recognition, being mindful of what we need to look for and how we identify this entity to seek further care and seek tertiary quaternary care expertise is of the utmost importance to outcomes. The need for frequent reassessment of the patient's hemodynamic status and the need for potential hemodynamic support, knowing that inotropic support is common. Serial imaging. This is not a single echocardiogram and we're done looking at these patients. Most usually we performed an echocardiogram on admission, repeated that in as early as 24 hours out or no later than 2 days afterwards if there are any findings of concern. And if everything's normal, we're usually looking again even in a week to look again at function and coronaries. There is a possible role for advanced imaging, including cardiac CT or cardiac MRI, particularly to look for coronary issues with the CT scans and functional issues and myocardial viability issues with the cardiac MRIs. There's dedicated cardiac MRI research underway on an international level to help us look at that. Finally, outpatient follow-up is absolutely necessary. We're very much learning about that, and the long-term ramifications of MISC are not yet delineated. So I would advocate that we will be following these patients in our clinics for some time to make sure that we're providing the best care that we can. And then finally, just the importance of the knowing when to seek care from a tertiary care center. This is an entity where multiple experts are involved to provide the best care for these kids. So with that, I'll turn it over to Dr. Hays to talk about immunomodulatory treatment. And thank you again for your attention.
Good morning again. So this next half will focus on immunomodulatory treatment, particularly looking at how we may modify the immune response in SARS-CoV-2 infection and miss that's a subsequent result. Next slide. This slide here is really to illustrate the remarkable effort that has gone into documenting and understanding what we are seeing in MIS-C, as well as documenting how these patients have been treated. I illustrated here the diverse groups that really have been involved. You can see the New England Journal of Medicine from a more broad perspective, critical care, cardiology and circulation, rheumatology, infectious disease. And then in the middle, it's just remarkable to see what is happening every day, as Dr. Tunks and Dr. Beck have shown, that we are seeing new articles published on a daily and monthly basis. Next slide. This slide here is a consensus statement that has been published by the American College of Rheumatology, and it's based on the recommendations that certain centers have put forth, as well as based on their documented experience with cases, particularly in MIS-C, but also in more of the acute setting, hyperinflammation and COVID-19. We will be focusing more on MIS-C here instead of the hyperinflammation, but if you would like to know more about this particular feature, you can find this on the American College of Rheumatology website. When they're speaking of hyperinflammation, this is similar to what the adults are seeing with COVID and pulmonary symptoms and the role of immunomodulatory treatment during those times. And the next slide here, taking a look at really what's going on and where we're seeing MIS-C begin in this setting. So on the left side of the page, this is stage 1, early infection. Most children are not going to be symptomatic, or if they are symptomatic, it's very mild and they may not even realize that they have been infected. Then stage 2 is something that, again, would either be mild or perhaps even skipped. It's more of the pulmonary involvement. But stage 1 and stage 2 really primes the immune system for this stage 3 that we're calling the hyperinflammation phase. And that's done by stimulating different parts of the immune system. So macrophage activation is thought to be the early activation piece that in turn leads to activation of parts of the adaptive immune system, which includes T cells. and production of cytokines. And these are areas for potential targets for treatment. If this is left unchecked and the cytokines remain elevated, this leads to further stimulation of the immune system and this exaggerated immune response that really just cannot be turned off until we intervene. We do not know clearly why some patients are more predisposed to this development. As we've shown so far, there seems to be perhaps a genetic link. We're seeing ethnicity differences over time. Hopefully this will be a little bit more clear to help know who may be more at risk for MIS-C, but it's more of a proposed theory at this point. And then the last point I wanted to make on that slide is that it's not related to direct viral injury, where that's more of a feature in the early stage, but this prolonged inflammation that leads to multi-organ involvement, you can see in this illustration, with profound inflammation throughout neurologic system, cardiac system, GI involvement, and occurs several weeks after that initial phase, which makes sense that they would not be infectious at this point because they don't have PCR testing that's typically positive. Their antibodies are positive in the majority of the MIS-C patients. Next slide. Immunomodulatory treatment. This was from the ACR, the American College of Rheumatology statement, and you first should begin with how sick is this patient and what other diagnoses may be going on that could cause a similar presentation to MIS-C. So first step is consider whether there's any life-threatening manifestations, and can you complete a workup for these other perhaps more common diagnoses and still maintain the safety of the child. And that's the recommendation, is that whenever possible, provide some basic supportive care and try to complete the evaluation, particularly looking at the labs and looking at the antibody testing to see if that is positive. We make note that antibody testing may not be readily available everywhere at the same speed, and it may be a delay to get that, as well as having all the complete testing. So if patients are sick, requiring ICU level of care, supportive treatment with pressor support, or certainly intubation, they may need to have ongoing diagnostic considerations and treatment with immunomodulatory agents. Next slide. The following list the more common medications that have been reported. I just want to point out there's no comparative data yet to tell us which is the best treatment approach. Much of this is based off of our experience with Kawasaki disease and knowing that IVIG has been protective in preventing coronary aneurysms. So there's a low threshold to use IVIG. In addition, IVIG tends to be overall well tolerated. It doesn't propose the same infectious risk that some of the other immune modulating agents can have, but we don't know the exact regimen. So that's just a full disclaimer we should say, but these are the medications most frequently used. High dose IVIG, we can split this dose if there's concern for significant cardiac dysfunction, or potentially cap it just to make sure we don't create more cardiac dysfunction or pulmonary edema from our treatment. Glucocorticoids are also used most frequently in the low to moderate dose range of 1 to 2 mg per kg per dose, typically up to a max of Q8 to BID dosing, and then pulse dose steroids up to a gram for each dose, typically in the range of 1 to 3 days, may be reserved for significant disease that isn't responding to IVIG or lower dose glucocorticoids. And there has been data to show that there is a portion of kids that are to have IVIG and steroid resistance that may require pulse dose steroids. And then the next two agents, particularly anti-IL-1 therapy, that's going to be Anakinra. And that has a very targeted impact on the immune system, targeting IL-1 that's very involved with fever production and inflammation. The dose there is what has been used in more of the adult literature that they've extrapolated from during the acute phase, but this is a dose similar to what we would use in systemic JA. There's also a max here. Anti-IL-6 would be tocilizumab, Again, this hasn't been shown to be as favorable for using upfront due to the longer duration that it lasts. It's usually dosed monthly. So if there is ongoing infectious concern during the workup, you may be better off using Anakinra that has a very short half-life and can be tolerated in most situations where there may be an underlying infection that hasn't been identified yet as a possible diagnosis. Next slide. They are recommending treatment tiers. So getting at what we had said on the previous slide, that you may be able to wait and watch in the majority of cases that come in that are considered mild. So supportive care with fluids, frequent vital checks, and lab checks may all be very reasonable. If they're coming in with mild to moderate, so there's signs of cardiac dysfunction, a low threshold to use IVIG, because we really just don't know the risk for coronary aneurysms and those that have signs of cardiac dysfunction if we don't treat. And low to moderate dose glucocorticoids may be either used alternatively or used together. But I would say from the recent ACR webinar that most patients are getting IVIG in this mild to moderate range, plus or minus the glucocorticoids. High dose pulse steroids are going to be used for more significant shock, and then refractory cases are really where we're using the anti-IL-1 and anti-IL-6 therapy. There have been more recent reports, particularly in adults, about using plasmapheresis, but this has not been used widely yet in children. And the last 2 points here, a point is we don't know how long this inflammation may last once we're intervening. So it's important to follow labs to guide your treatment response, as well as their clinical picture. We should see improvement in fever, symptoms, as well as those lab parameters over the course of several days with treatment. And if that's not happening, it would be a reason to escalate or a reason to stop your taper and wait and reassess. And the last point here I put on there, IVIG low threshold to use, because we don't know in these cases of incomplete KD, if they don't fully meet criteria, is that an exclusion for IVIG? And that part's a little bit out. We may see over months that coronary aneurysms in these patients aren't a big concern compared to Kawasaki disease, but we don't know that at this point in time. Next slide. This graph here, or this table rather, just illustrates treatment in existing cases that have been published from some of the experiences at cohorts in New York and the Northeast, and illustrates the wide variety of treatment options, but showing that IVIG, steroids, Anakinra are the major medications that have been used. There have been some reports of anti-TNF treatment like infliximab also being beneficial. Next slide. I thought an illustration of IVIG just in general to see how this might impact different parts of the immune system would be helpful for the audience. The main point I wanted to point out here is that IVIG has a broad impact on the immune system, and particularly for COVID, it may be important with the anti-inflammatory effect it has on cytokines and neutralizing antibodies and damage from complement. And the next slide will illustrate some thoughts behind IVIG and SARS-CoV-2 in MISC. Next slide. And we'll just focus on the right side of the page. You can see at the very lower part of the screen, cytokines are shown, and this is one theory that the IVIG, those two bars attached to the cytokines, are going to neutralize that effect. The other area they find that it may be working is directly binding to the immune cells that are getting activated by SARS-CoV-2, the macrophages, and binding that interaction between the macrophages and the viral particle antigens that are on the surface. Next slide. And then lastly, just an illustration of how Anakinra might work. So it's an IL-1 receptor blocker, and very important in fever, inflammation, pain, rash. And you can see that lower part of the screen where the Anakinra molecule will bind to that receptor and prevent IL-1 from binding and causing that downstream inflammation. And it has a quick onset and quick half-life, so you can start it and see an impact pretty quickly within a day or so, and then also be able to stop it if you were concerned about any interactions and have the drug out of your system pretty quickly as well. Next slide. The last slide I have here is about treatment response, just summarizing what we have talked about. And I wanted to reiterate the point that we've made thus far, that NASI is pretty uncommon in the incidence of cases when you look at it as a whole. So, reassure patients that it's not very common, but it is something we're learning more about and seems to be treatable. Most cases are responding to the treatment regardless of the combination that's being used, and also with the supportive care that they're getting and seeing a turnaround and improvement within days to weeks. And those cases where, unfortunately, some patients have had a prolonged course and even, unfortunately, death, some of those were early in our experience. And so it's hard to extrapolate what our death rate or morbidity will look like until we have more time go by and see how a broader range of patients are doing. The next point, tapering is going to be important because it may take a different amount of time for this to resolve for each patient. And typical duration after you see improvement in their labs, particularly CRP, would be 2 to 3 weeks of therapy, particularly for the steroid course that you're using. And then the last point are long-term implications. While most of the patients seem to be doing well initially post-hospitalization, we don't know what this may mean for their cardiac function at the micro level, or if there's any implications there that need to be monitored. We also don't know if they're more prone to developing a similar response to other infections or be more predisposed to rheumatologic disease. It'll be important to monitor these concerns over the several months and years to come. And we will next just go over overall highlights. I think Dr. Beck was going to take us through the lessons learned, and then we'll open it up for questions and discussion. Thank you.
Thank you. I think hopefully we'll be able to, one, create an awareness for those who haven't seen MISC or a hyperinflammatory phase of COVID infection, that we've alerted you to things to watch out for, whether it's the phenotype and or the lab abnormalities. Because one of the things that we've seen emerge is that the children can look pretty well, even if they're mildly ill appearing, is their labs can be significantly deranged. Sometimes there's a lag behind that. So hopefully that some of the things that we talked about will give you some understanding of what you see and how it's an evolving disease process. And it has a broad spectrum of presentations. Regardless, as all I think the speakers have said, is that these kids can get pretty sick. I hope we'll be able to stress that. So as a tertiary center, we're happy to take these children even for observation. If you're not something you feel that you can manage or follow these kids closely, if they're the mildly ill appearing ones, that we're happy to see these kids and take care of them and watch them for a day or two, even in the hospital, to see how they evolve. Because some of it does just require data trending. Obviously, the sicker the ones will have to come to the intermediate care or intensive care unit. Most places are advocating for a tiered approach, which we can talk about if there are any questions about that. And then also give you an overview of what types of therapies exist, the variety of what things we're using at our center, and then the follow-up that is going to be required after all the consultations are made at the Children's Hospital here. So hopefully that's the nuts and bolts of it, and obviously available to answer any questions at this point.
I would like to thank all three of you for sharing your expertise. I think each of you could have presented an entire hour on your area of specialty, but it was a really nice flow. So let's open it up to questions. First, anyone from our participating providers, if you have questions, And if not, I would encourage our three presenters, if you have questions that you would like to ask of our participants, feel free to do so. And you're more than welcome to unmute your microphone or to put comments into the chat box. If there aren't questions, I hate to put our three presenters on the spot, but we could pull up that very brief case that you had, if you'd like to walk through that.
There are some questions just came through.
Yep, we do. So what follow-up is done during outpatient recovery phase? Do you follow inflammatory markers, post-hospital discharge? If so, how long? Do you do a follow-up cardiac echo post-hospital discharge?
I can comment. Oh, go ahead.
Go ahead. Okay, sorry about that.
No problem.
In terms of hospital or post-hospital imaging and cardiac evaluation, the answer is absolutely yes. So what we have proposed is that if function has normalized in the hospital and there are no coronary issues and no pericardial effusion, if everything is looking well, that we would still see that patient similar to a Kawasaki follow-up in about 2 weeks. You know, longer term follow-up, I think we're figuring that out in terms of how long to follow these kids if everything normalizes. But I would advocate for that, especially early in this experience. But we're seeing all of these patients in the clinics after their hospital stay for cardiac evaluation and reassessment.
In regards to the labs, I can comment on our experience with a couple of cases, and then Mike, please add to from your thoughts. So inflammatory markers definitely will be important. I think that was part of the question. CRP seems to be the one that other centers have recommended for monitoring the closest, because it tends to show improvement faster than some of the other markers and may help you guide treatment. BNP, ferritin may stay elevated for a longer period of time, but the general trend should be improving. And I think you would want to make sure you're not seeing a rise in labs or symptoms during this taper period. It's hard to give an exact date of you know, what frequency to be checking at. I would say if someone was hospitalized and still had inflammation at the time of discharge, you would want to see something within the 3 to 7 day period, depending on what was going on. If your plan was to taper weekly for steroids per se, to have them off in a 2 to 4 week window of time.
Yeah, the only thing I would say is that in terms of what I've seen is if some people are also following the D-dimers, which is sort of a marker for hypercoagulability, or at least clotting involvement. We're not doing what's called TEG or thromboelastography here, which they are doing in adults, and they found that people with elevated TEG markers will have a higher incidence of predicting people who are going to have clots in the adult population. I met with our hematologist and benign hematologist, and we are not doing that in kids at this point. But what they are following is an outpatient. If it's a mild child who's not getting therapeutic doses of anticoagulants, whether it's lumaquid, heparin, or Coumadin, most people are still using an aspirin, whether it's a 3.3 to 5 milligrams per kilogram per day with a max of 81 milligrams, as long as there's not thrombocytopenia with it, with less than 80,000. Some people are following the D-dimers, and if there's no other strong reason for anticoagulation, like cardiac dysfunction or aneurysms, some people are using aspirin until the D-dimer normalizes. There was one question about parallel syndrome in adults. I don't do adult medicine. I have in the past. What I have seen in some of the literature and presentations from adult immunologists is that there probably is some component of hypercytokine storm or cytokine release syndrome, since we know it's a late manifestations of the recovery phase of clearing the viremia, and it's usually an antibody-mediated process. Since it's usually in the 2 to 4 weeks, a lot of these patients, I think, in the adult population who are in intensive care are experiencing the MISC syndrome while they're in the hospital, which is why some of them are being treated with tocilizumab or therapeutic plasma exchanges. So I think whether there's a true parallel, I think that'd be the closest parallel. I'm talking to some of our intensivists here. The patients who are getting it are responding to tocilizumab.
So in the interest of time, thank you for the questions that came in. I would like to thank the presenters again. This was a topic that we had several requests for, so we really appreciate your time. Those who are participating, remember that you're able to collect CME credits for participating today. You will receive the survey link following the session. I believe Michaela has shared the link for all materials, but we will also share those via email. And we'd like to thank you again for your interest and your participation. If there are any last questions before you leave, please put them into the chat and we will respond via email. Thank you.
Thank you all very much.
Thank you.
Thank you.